Hello, everybody. Our patient, we can go to the next slide. Um, yeah. Our patient is a female patient, 71 years old. She has insulin-dependent diabetes mellitus. She's an ex-smoker. She suffers from hypertension, hyperlipidemia, and has asthma and von Willebrand's disease. And she has she presents to our clinic with a non-healing ulcer on the left toe. And she's on guideline-directed medical therapy, and her ABIs are, as disclosed on the left side, more significant lower than on the right side. And we are approaching an intervention right now.
Basically, she had an ultrasound that was done in our lab, which showed occluded left anterior tibial artery with really flow from the perineal, which gave the communicating artery, which then filled the dorsalis pedis, but with a lot of disease in the foot. And I want to show you this. You can see the iliac system is okay. The superficial femoral artery system also is okay, because we had a good ultrasound that showed all this was good. And then as you go down here, you have a distal or a proximal anterior tibial artery occlusion, as you'll see shortly, right there, with the perineal arteries there, and the posterior tibial artery also occludes. And then at the level of the mid, it's a long segment occlusion, but I believe there are some hibernating areas, which we don't really see well because it's an angiogram. And you can see the distal AT come back. And then you can see here in the foot, and the reason she has the non-healing ulcer in the great toe is that the flow in the dorsalis pedis is poor, and obviously the arch is also poor. So at this stage, I think establishing straight line flow to the foot would be something good. So what we've decided to do is we just basically got our catheter over there. We're using rather than do pedal the way Andre did, I think the distal vessel is very diseased in this segment, and the perineal is quite robust, and still the ulcer is non-healing. So what we wanted to do is do an antegrade approach and do wire escalation and talk about different wires that you guys would use so that the audience and I can benefit from your experience. So just from like all of us do, I've buried a support catheter, which is a teleport catheter from CSI, which we find in coronary CTOs works really well. And we have a hydrophilic wire, I believe. Mm-hmm. Yeah, we're going to use a command wire here, and then go ahead and try to get through these hibernating areas before we go ahead and hit the CTO. So I don't know if anybody would do this differently, but this is kind of our idea. And I'm going to just start working with this wire while you advise me.
So first of all, the antegrade approach is clearly the way to go here. You know, you're going to have to reach the foot. You've got a beautiful SFA proximally. You know, this is a no-brainer for the antegrade, so we like that.
Okay, so right here, this is the area where there was a little hibernation, which I'm anticipating is going to be there. That's why I took the hydrophilic wire down. But you'll see over here, somewhere here, you'll see right there, that's going to be your occlusion. So this is the area where it's occluding. So I think we all have seen in our practices where we get the hibernating area and then an occlusion and hopefully another hibernating area. So this is the area where I don't know what does everyone do, because I still try to go with a hydrophilic wire in this area and try to see if there's any fenestrations. There we go. There's a fenestration. So there we go, another occlusion. So we try to find fenestrations with these wires. Wow, yeah, not quite going, is it? Okay, let me just bury it there for a second. And I think, Chris and the panel, this is the area where I think a true antegrade access might have helped even more, even though we were able to bury the catheter in the SFA.
So PK, this is Fadi here, and obviously you know I'm very biased. And Chris is looking at me already. He's like, don't even think about it. But you know, this is actually a great demonstration. I would say that sometimes in antegrade approach, I mean, we'll talk about the CTOP trials and the predictors, but you know, can you tell us in your mind? And I think it's very thoughtful. It's very important points what you mentioned. What were your concerns about retrograde pedal access in this case?
You know, there you go. You know what we do, Fadi? We you know, in our hands, we always want to give one attempt at antegrade failure. I mean, I think you're right. We could. It is like Stephen said in the other case, it's not a horrible toe ulcer, but it's a chronic painful ulcer that this poor lady has. So to me, the entire foot is alive with that small little vessel. So, without giving a rapid go here with an antegrade approach, I don't know if it's prudent to just go to the retrograde. See, I think that, even if I'm having trouble getting this one down, I can go ahead and do balloon angioplasty of the track here and maybe be able to get a support catheter like a coronary guideliner and then try to be able to have a little bit more pushability. But I'm just, that's part of the reason why I don't jeopardize that particular vessel as of yet. See, I hope that's it. Let's see, so far, it's kind of sliding along there.
Good. PK, what's that support catheter? It's got a radiopaque tip, it looks like it's got a little angle, and it looks pretty nice, smooth taper. What is that?
It's a teleport catheter, Chris. It's CSI makes this catheter, and this catheter is actually has really changed our practice in these kind of difficult cases. It allows us to be able to track it down. They use it for coronary CTOs, transcollateral crossing, and our coronary team is quite advanced in those abilities. Yeah, I think we crossed. See, our coronary team is quite advanced in their abilities. So, I always, we cross-pollinate like we all do in our labs, and hopefully that cross-pollination will help this lady.
Yeah, teleport.
So I'm still with the hydrophilic wire, as you can imagine. It's really just a hydrophilic wire there. See, I've got another occlusion here. I may have to balloon this before I'm able to get down any further. Yep, I'm gonna have to balloon it.
PK, question
Yep.
here.
240
Antegrade common femoral artery access versus being up and over. What are your thoughts on that?
I know that the Italians, especially with all their Roberto and even Steven, when I went to Singapore and met both of them, they both have always told me, like, always go, antegrade in these kind of difficult cases. For us, the radiation, and it's, I don't know, for some reason we do antegrade but we always give it an attempt up and over, and we've had good luck in even difficult cases because of what you said, Fadi, which is just convert to a pedal approach. This lady's prepped to have a pedal approach, and we'll convert immediately if we after a few attempts if we fail. So yeah, I think the only advantages there are pushability and obviously the ability to deliver devices much better.
I think reachability goes along with pushability. And I mean, in the case we saw before that, they had poor flow into the SFA, which can make, sometimes your inflow is a problem if you got disease in the proximal SFA. This one looked wide open, so I think if they're not too much of a panis, I would prefer the integrate for the pushability and reachability.
Do you do a lot, Chris?
Yeah, again, you individualize. Sometimes in Tennessee, just like in New York, you get pretty big panis, so that makes it hard. But if you don't have the panis and you don't have disease in the proximal or osteo-SFA, and we're going to go, the more distal in the foot that we have to go, the more I'd want to go antegrade, so that I could make sure I could reach with anything, not just one balloon, but maybe a stent or anything else.
Prakash, what balloon is that?
This is a 2030 coronary balloon, guys? Yeah.
NC.
It's an NC down. It's an NC Abbott. I think it's an Abbott balloon, right?
Emergent.
And what we do is we're just ballooning this with a monorail balloon, Rob. We also have a what is it? A point 0.9, right?
0.9.
We have a 0.9. No, 1.6 we have, right? And we have a 1 millimeter balloon from Boston.
1.5,
Go up here.
1.25, and a 1.
So I start with this just to get a bigger track up top, and then the next I will go with the Boston balloon, which is going to be a little bit less down, which is the 0.9 or the 1.0. 1.0. Sorry.
It's from
Down?
it's from Azahi, I think.
Down. What is it from?
Orbus Niche.
Who makes it?
Orbus Niche.
Oh, I don't know. He'll say that better. What is it again?
It's the Sapphire Pro 2.
Okay.
You can
so
show it.
You guys got that right?
Sapphire.
Are you?
I got
This is an
teleport.
RX balloon or it's an over-the-wire balloon?
It's an RX balloon.
RX,
And this is the, yep, go up here, guys. So you can see here, I'm trying to get it. I think it's that wedge of calcium that we were able to sneak through down. But unfortunately, the balloon's not going. So I'm going to have to go with the
Sapphire.
the 10 balloon. Get us a guideliner here too, please. So a lot of times what we do is we use a coronary guideliner to be able to give us additional support. So as I think the cardiologist in the room definitely will know this, it's basically an extension that we use. It's like an extension of a sheath that you can place all the way down at the ostium of the AT which will then give you sort of like a mother and daughter, or a mother and child, I should say, type of approach. Is that right? Is it mother and child? Yeah, mother and child. So this is what I'm going to do. I'm going to take the guide liner down, and I'm going to place it at the level of the ostium. Fadi, you probably don't have to do this because you're doing it from retrograde, so pushability is never an issue for you.
But
Show me both.
I mean, it's important to point out
Right.
that there are different ways to tackle CTOs, and these are some of the tips and tricks, because the majority of operators in the United States still, depend on being up and over approach, and some patients, like you mentioned, were not able to do integrated access. So this is actually very nice to see what are some of the tips and tricks. I want to ask you, PK, though. I mean, obviously, your team is very efficient and you're very skilled in doing this. And something that we did not even mention is the fact that you're very comfortable ballooning without IVUSing or confirming with extravascular ultrasound. And part of it obviously is your experience because the way the wire behaved. Can you
Right.
comment on a little bit on that more? Like, why are you comfortable saying, okay, I'm not outside the vessel, I'm not subadventitial? Is it just simply because of the way the wire behaved?
Yeah, I got to tell you, that's kind of the reason why. You can see here, this is going to be a real pain. I think the reason, for me at least, the way the wire behaved, I knew we weren't free-flowing in the tissue, like we hadn't perfed all the way out. We might have been in a dissection plane adjacent to the vessel, but to me, that's not my worry. My worry was here, let's try to get as close to the reconstitution cap as possible. Go up here, guys, and then go ahead and do it. If the wire was flip-flopping back and forth, then I would agree that I would be a little bit concerned. So here, just because the wire was kind of smoothly tracking along, I really sort of felt that it's just kind of tracking along the vessel. So this is going to be a real issue here.
Can I ask Robert here? Robert, would you consider IVUS before you balloon, or would you not necessarily IVUS?
Not sure I would send down an IVUS. I think he's having a hard time even getting
Yeah,
a
give me the support
1.0
catheter.
balloon catheter to get down to the tip of the wire. I'm not sure I wouldn't do an angiogram at this point.
Okay.
Maybe in the popliteal artery, you've got that support
Just do an
catheter
angio?
down there. Do a dedicated injection in the popliteal, and then see if
sorry.
you can figure out whether or not the reconstituted DP is lining up with where your wire's coursing. And if it really did line up, I'd feel probably comfortable ballooning it very, very gently.
Well, unfortunately, I have a lot of overlap here, but we're going to go to another view. I'm sorry about that.
Okay.
Prakash, Jose here. Sometimes if these catheters don't work, you could use other crossing catheters like Turnpike or Corsairs, particularly when 010 balloons don't work. 1.0 balloons don't work. Sometimes these support catheters help out.
Yeah, so we have a support catheter here, Jose. We're using, you can see I'm kind of lined up right there. And so I really feel that now the flow is good to that point, and that's the ridge of calcium. And so what we've also sometimes had to do is take out the wire here and then put a CSI wiper wire down, and then maybe run a CSI through here, because I don't think this is going to cross. We had a similar case we did for Arch with George Crescent, and this was a similar kind of case that really made life very, very difficult for us, where we were not able to get anything done, although the wire went. So I think you guys need to rail me here, guys.
So let me just throw it out here to the panel. We've seen incredible cases. Andre was doing an amazing retrograde case. This is clearly a challenging case. What's the need right now for a below-knee reentry device? Would a below-knee reentry device solve this?
Nope.
I don't think so. If you can't get this little support catheter down there,
Right.
and then you're hitting a small lumen, I would say no. I think it's persistence in the techniques that are being used. That's my opinion.
Okay. What about on the previous case that Andre was doing, where he was having a tough time with that wire? Obviously, Andre's very
Yeah, look at
skilled,
that.
and he has an armamentarium of different wires. But do you think a reentry catheter would have helped there?
You're still going to be using it through a tibial access, so small
Yeah.
sheaths.
Yeah,
I guess it
yeah.
better be small.
No, it would have to be 3 French, something like that.
And then you're also going back into the trifurcation. If you remember
Okay,
Andre's case, I'm not sure I like re-entering at the trifurcation.
Right.
Just system thought.
That's fine.
I mean,
So-
sometimes you could use coronary reentry devices like Stingray for small vessels such as tibials. It's a little cumbersome to use them.
Yeah, I would tell you that delivering the anterior there if you're not able to deliver a 1.0 balloon. I mean, obviously we're not talking about this case, but it might be challenging because it's even though it's a lower profile device, it's still somewhat difficult.
Give me a Viper
No,
wire,
no,
guys.
Stingray.
Yeah.
So what I'm going to do is try with the Confianza whether this gives me a little bit more body, Fadi. I don't know whether you like these wires in this, or the panel, even Rob, whether you like this wire in this application. But sometimes these stiffer wires rather than the hydrophilic give you a little bit more body, and you're able to get a little bit down. Show me now. Let's see.
You're actually doing pretty nicely there.
Yeah, you know, it's just the way it's moving. I know it's worrying all of us. It's just kind of moving a little too freely for my liking, but let's see whether I can get it a little bit further
Again,
down.
I think this is a great time to, if you're just making progress, to repeat the angiogram and see if you're lining up, because you saw
Yep.
the distal AT
Yep.
very nicely
Yep,
before.
let's hit an angiogram. Oh, sorry, DSA. So I think what's going to happen here is we're going to cross, and I think what's going to happen is we're going to have to work with the.
PK, we're going to interrupt, and we're going to go back. We do have transmission from Leipzig, so we're going
Yes.
to go back quickly and see what Andre has come up with his case.
So Mike, what I did was we'll show you as Vishal walks this out. You got to do it off Flora. So what we did was when we were away, we just went ahead with a Confianza wire like we talked with Rob about, and then I took the support catheter way down, and then what I did was I switched out to a Corsair, and then was able to advance the Confianza wire all the way into the foot. As you can see, we're in the DP here. And then what I did was I took the Corsair and twisted it and made a circular motion, was able to get all the way into the foot from above. As you can see, it's a good DP, and you're right, Fadi, we probably could have stuck it. It looked very diseased, but it wasn't that bad when we're in there. I'm sure ultrasound interrogation might have helped me more here, but I'm sort of like Chris Metzger, don't do much of those usually. And then so now I'm here, and I've crossed. So I know we're probably out of time. So what we're going to do is, I just want to let the audience know, we're going to do an IVUS, directional atherectomy, balloon angioplasty, and then if we need to do provisional stenting, we'll use a DES. So, so I think this is a nice demonstration of an antegrade cross. And if we have time, Mike, we'll stick around, but I know we have to go 4:35 to the other one. I don't know whether you have lectures, and you can just leave us on one side while we work here, and we can work while you guys do lectures.
Can we go back
Mike?
to New York? or where?
We have here.
Okay. Okay.
Mike, I just want to show you we got way ahead right now. That's enough. Okay, she's having a little bit of pain because we're using a big balloon. Ready? No, just keep it up. So I want to show you what we
Almost
did.
there, sweetheart.
So we did a quick balloon angioplasty, and now this is what we have. So we did a balloon angioplasty all the way down, and obviously we restored straight line flow. Right now we're using a larger balloon. That was a 2025 balloon?
Yes,
2025 balloon, and this is a 2530 balloon. And then we're going to leave this out for about 8 to 10 minutes, and then take a final picture of the foot, and then decide whether we need to do any adjunct therapy. So I think we're gonna end here because I think the results are pretty good, and I think we'll be able to establish we have no perforations, and the wire went pretty smooth into the foot. So I'll show you where this balloon is inflated right now. Flora, please.
Yeah, PK, that looks fabulous so far. Yeah.
Yep, and here's now the 2530, Mike, and she's having pain because it's obviously, I really believe we all undersize our tibials a lot. So, I'm being a little more aggressive than I should. I guess IVUS would have helped, but because of time, we didn't do it. And I think right now we did a pretty good job. We'll stop here, and I'll get the other case ready, and you guys can keep on schedule. So thank you again.
All
Great
right.
job,
Great
guys.
job.
Thank you.
Great
Okay.
job.